Good afternoon and welcome to HealthSystemCIO.com All-Star Panel, Keys to Meaningful Patient Engagement, a webinar tweet chat combo from HealthSystemCIO.com. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of HealthSystemCIO.com, and I will be your moderator today. We do have a simultaneous tweet chat going on, being hosted by our managing editor, Kate Gamble. And if you want to participate, you can open a separate browser and use the hashtag HSCIOchat. And if you just want to view it, you can do so in the Media Viewer panel on the right-hand side of your WebEx console. There'll be a few things going on in those consoles. As I said, you'll have the tweet chat. We're going to do some live polling, which will be in the polling panel. And you can submit questions in the Q&A panel. Leave the default set to all panelists. Just type in your question and send it in at any time, and we'll take those later on in the program. You can also download the deck by using the URL on your screen, and I will send it out in the chat box shortly. Just so you see how we're going to spend our time today, we're going to have our panel discussion first with Ed Marks, who's with New York City Health and Hospitals Corporation's IT leadership team, and Jeff Pearson, VP and CIO with Christus Trinity Mother Frances Health System. And you'll be able to look at their bios as they're speaking. I'll put those up. So let's get started. I want to go first to Ed. Ed, can you give us an overview of your organization, please?
Yeah, so I'm currently serving New York City Health and Hospitals. We are 11 hospital system. It's the second largest public health system in the world. It's the largest public health system in our country, about $8 billion in revenue for those who look at those sort of measures. But our mission is really to serve the underserved in the city of New York.
Very good. Jeff?
Yes, good morning, everybody. I'm Jeff Pearson. I'm from Trinity Mother Frances. Actually, I'm sorry, I should apologize. The Christus Trinity Mother Frances Health System. We're located in Tyler, Texas, a couple hours east of Dallas. We started out as a hospital back in 1937, so we were about to celebrate 80 years here in East Texas. We merged with the Trinity Clinic in 1995 to create a an IDN that has a large multi-specialty medical group with about 350 providers, as to where it's grown to over time, about equally split between primary care, specialists, hospital-based providers. We have about 600 hospital beds now across our main Tyler campus and 3 regional hospitals. And we partnered with Christus Health in this past May, a very new development for us, and this formed Christus's Northeast Texas region. So we've joined Christus's about 40,000 associates across Texas, New Mexico, Louisiana. They also have a big presence in Latin America, in Mexico, Chile, and Colombia.
Very good. All right, Jeff, let's stick with you. I think a good place to start would be your philosophy of patient engagement. You could touch on 2 aspects. You could talk about the organization, yourself personally. We assume those are probably in line, but if there are any differences, let us know. So go ahead, Jeff.
Yeah, absolutely. I think they're in line. So I think we'd all agree that the really patient engagement really starts in the patient encounter, whether that's the exam room or the inpatient encounter. This is not a technology thing. This is about how you really engage with the patient and seek that patient satisfaction, and of course the impact that leads towards great outcomes. So we have a lot of initiatives that we do simply within the patient engagement realm around Studer and rounding and ADIT and some of those tools and initiatives that are used to just really make sure the patient realizes that you're there to help and they're being heard. We also, of course, want to provide multiple channels for the patients to engage, whether that's community events, whether it's care coordinators reaching out via the phone calls, of course the counters in our locations of care, and then lastly our patient portal and how that can do what that can do to help engage the patient, and all of these different channels come at a different cost. And so that's something that we've really strived to see to what extent the patient portal can meet the needs of a large segment of our population. So to help do that on the portal side, you want to make it as full service as possible. I think you really want to try and match, if you can, the quality of the online experience that customers see in other industries. That they're very used to. Many of them are very used to doing their banking online, making other types of appointments online, and paying, of course, a lot of the bills and doing online shopping online. So we want to make sure we can make that as seamless an activity as they're used to.
Very good. Ed?
Yeah, I should also mention that previous to my position with New York City, I was with Texas Health Resources I had the privilege of serving there for 7 years and 6 months. And so some of my answers will sort of be a blend of both what we're doing in New York City and what we've done in Texas Health being a much more mature organization in terms of patient engagement and technology versus New York City, where we're just now getting our start. So my opinion does differ a little bit from the organizations in which I've been privileged to serve. But I think from an organizational point of view, it's all about, as Jeff was saying, that it's very patient-centered. And ideally, that engagement occurs before they are ever a patient. So we try to reach out to the community. And one way that we've done that, so there's a lot of different mechanisms, obviously, and we're here to share, our experiences. But, we have this thing called the Blue Zone Project based off a book by Dan Buechner called Blue Zones, about healthy communities, what really makes a healthy community. And healthcare is actually just a small part of that, but we have a responsibility as an organization, because we're such a key part of any city, as a healthcare organization, to really be part of that process. So again, the philosophy being patient-centered care and reaching out into the community before the citizens ever become a patient. I differ a little bit. I mean, I totally agree with that, but I think we need to make a lot more aggressive strides towards engaging patients and making them responsible for their health care, because at the end of the day, it's really about the patient choice, whether or not they're going to adhere to medications, whether they're going to adhere to any sort of protocols. So in today's environment, right, the payer puts the onus on the provider to ensure quality of care. Well, there's only so much you can do, because ultimately the patient makes the most important choices of all daily on how they exercise or eat or not smoke and those lifestyle issues. So I think if we want to really transform healthcare, we really need to engage the patient, but in such a way that they are held personally accountable for their health, not necessarily the provider. So that's my little nuance.
Ed, let me follow up with you. We're talking about also making them financially accountable, correct? I mean, right. Isn't that where the impact, right? That's where the change has to come. It's got to hit you in the pocketbook if you're making poor health decisions or not complying with what your doctor's telling you to do.
Right. Unfortunately, you would think that just the benefit of being healthy would be enough motivation, but as we all know from what we see in society and the studies that have been done, that's not always the case. Now, clearly, there's people that are sick that, despite doing everything to keep themselves healthy, they're sick, and that's what's great about our healthcare system. And we have such top lines of medicine in our country that to help people when they have in times of need. But I'm talking about when there is something that we can control. Yes, I think unfortunately it comes down to sort of financial responsibility. We are seeing obviously some transformation in that area, right? I think my own benefit plan has changed over the years to where I'm more and more responsible about the dollars spent and the dollars that impact me. And so I think that is helping drive a behavioral change. But I think when we engage patients, that's where I'd like to see more emphasis, because until we do that, I don't think we're only going to get incremental change, not transformational change.
Jeff, you want to touch on this idea of responsibility when it comes to patient engagement? Who's responsible?
Right. I mean, I agree that there's only so much we can do to observe patients' behavior and activity, or to incentivize them to comply with those kinds of initiatives that Ed was discussing. My wife's a nurse practitioner, and she's worked in transitions of care and seen patients in nursing homes and homes after discharge as part of a bundled program, and she I can't tell you how many times she's come back in the evening and told me about the patient she saw who's either never gotten their medications or for whom the medications were sitting on their counter still in the bag and never opened and never been taken. And so, we do our best to get input on that, and certainly to the extent to which we're being held more accountable through programs like our ACO and other bundles, we're very much now incentivized to at least attempt via, whether it's phone calls or others, to reach out to that patient and try and encourage them, find ways to make sure that they are not hampered by other barriers such as ability to pay, or they're getting prescribed, non-generics when generics would do, and all those kinds of things to try and make it more capable for them to afford the care that they need. But so absent being truly able to flip a switch in our patients when they arrive that says, I'm going to do everything my doctor says, I think we just need to make the transactional costs as low as possible so we can afford, but still make it effective in staying in contact with them and finding ways to get their feedback and determining the progress that they're making. And it's not easy. We have a big, of course, self-insured population of our patients and of our employees and their dependents, and we've done a lot to bend our own curve. Actually, have cut costs, seen our medical plan costs go down through efforts we have done for our own internal population health management, and that doesn't happen very often, and it takes a lot of hard work, and it takes some of the same strategies I was just mentioning.
All right, very good. Let's talk a little bit about projects and results. Ed, you want to start off? And again, feel free to talk about your work at Texas Health. And I think one of the interesting things that you might want to touch on during our talk today is the fact that you were at Texas Health. You mentioned it was a more mature environment. New York City hospitals, health and hospitals, you're just getting going. So you've got an interesting perspective on sort of getting to the higher level, but also getting things moving from scratch, or maybe not quite from scratch. And those are two different challenges, but start anywhere you like there.
Yeah, no, for sure. It's the same problem in both cities, everywhere, right? To take that magical bullet for how do we really engage patient health so that they feel responsible for their outcomes and are part of the overall process. And it has been interesting to go from one organization that was just further along. It's not good or bad. It's just where they were, and it's the difference between public health and sort of the private sector. And the great thing about New York City is they have made tremendous investments, and they fully expect to be at the same level as like Texas Health and any other organization. And so it's pretty fantastic to be brought in the early part and to help be part of that process. But that being said, we kind of look at things in three buckets, and these buckets, the lines are blurred a little bit. It's not perfect, but when you form a plan, sometimes you need a little bit of structure. So I think one bucket is sort of clinical things. One is social, and the other is sort of the business functions. And again, these all sort of meld together, but there's different ways of looking at things. I don't think anyone has to have the same structure. It's just you need to have some structure to help drive your strategy and get to execution. So anyways, under the clinical side, those are things like the portal, right? I think most of us are probably used to now having a portal that's should be pretty standard, especially for more mature organizations offering patients a portal. And then through that, you can do quite a bit. And now we're seeing the emergence of telemedicine. So where I came from, we were starting to do telemedicine. And I know as an employee of my organization, telemedicine is a great way to engage and helps lower costs. And I think it's still early to talk about quality because we haven't seen a lot of data yet. But I know that we utilize it as a family quite a bit, and that tends to engage us more. It's like, we're more quick to take care of issues before they become real big problems because it's so easy. So we're engaged in that way. But then on the social, it's just doing things like, what's your heart age? I know many communities have tried things like that. So you go online and you answer some questions, and it tells you kind of your heart age, and if there's seems to be a problem with in the logarithm that, based on your answers, and they might suggest, hey, did you know you had a cardiologist in your neighborhood you could see? So engaging socially, I could go through a lot of examples, but for the sake of time, that's just one. And then the business function, and whether we're talking about automated appointments or appointment reminders, and I can go in later, to tell you some of the impact that we've had. But those are some of the projects, or prompts, the text messages, prompts about your appointments coming up, prompts about medication adherence, and some of the outcomes we've had with that. So those are the three different buckets, again, clinical, social, sort of business function, and some examples from each.
And let me follow up with you, and I might be cannibalizing some of our future questions, but are any of the tools per se, from an IT point of view, hard to implement? I mean, that's not the problem, is it?
No, I don't think that, some of them are pretty low cost, like doing any sort of health index, right? Very low cost, very easy way to engage patients, or, some of the other ones we had were things on basically on YouTube, and, every day was a different, sometimes it was an exercise, sometimes it was a mental health exercise, and we had thousands and thousands of hits and people saying how it's changed their lives and helped make them healthier, and then it also offered a channel into our health system. And again, we didn't want, our goal is not for anyone to be a patient, but if that happens, we want you to come to us. And so these were great channels to engage them to be healthy, so they never had to come to us, but when the time came that they did, that they would come. So yeah, the answer is that, I mean, that's just an easy example of how low cost it is. So it's really not so much about cost, although you can argue a portal would definitely be a higher level of investment, but some of these things are so simple that I'm not sure why, I think everyone should start off slow. I know I'm jumping way ahead, but anyone could start off slow, and that's what we try and do here in New York City, is let's do some of this easy stuff, and we will build up to the other things as our infrastructure becomes more mature.
All right, very good. Jeff, you want to talk a little bit about sort of your projects and results, and feel free to touch on the things we've been discussing about the concept of, on the IT side, it may not be that difficult, but go ahead, anywhere you want there.
Yeah, no, Ed touched on a lot of great things that I think certainly apply here. Portal strategy is definitely table stakes if not just for meaningful use, but reasons, but really to drive at some of these patient engagement approaches, which is, of course, the government's intent when they wanted a higher level of that through the meaningful use regulations. But I mean, I think there's very real efficiencies to our own operations that we're seeing, and of course, I touched on that as well. We know that the level of medication advice requests we get per month, 14,000 of those every month, and the 4,000 or so medication refill requests we get every month through our portal is almost every single one of those is a saved phone call that might lead to a voicemail, that might lead to a call back, and it gets a voicemail. It's frustration for the patient, and it's something that has to be done within the workday in many cases. And when you do something like that on the portal, you make those requests, and you get the answer can be much more asynchronous, and it makes one request lead to one response, and not a lot of back and forth, and certainly is more streamlined and easy to prepare and provide. We have thousands of patients signed up for electronic bill pay, which means that, or electronic statements, which means that they don't receive a statement anymore. They get that through the portal, and they our statistics are showing that those patients are signed up for that are 3 times more likely to pay their bills, or my chart patients are, and they do that electronically. We collect hundreds of thousands of dollars per quarter on the through that channel, and that's much more efficient for the patient and for our staff, and of course bill questions can be provided. And then making a request or actually scheduling directly an appointment with our providers is something that can be done in the evenings or weekends, or and not have to rely on the same timetables in which our phone lines are typically staffed. So those are all efficiencies that I think we really see. And then the last one of that is the a big project we've been embarking on this spring has been around making more and more of our paper questionnaires that a patient might otherwise need to fill out upon arrival and be told to arrive early for their appointment and so forth, and answer some of the same questions they've answered over and over. We put as much of those as we can on the system so that it can be done in advance at a time that's convenient to the patient. And in that process, took the opportunity to streamline those requests when we realized, in most cases, a lot of the information is already known, and we've just been asking it out of habit over the many years using the forms. So that's one big bucket of projects that I just want to say how we've tried to refine the portal and to get the most benefit from it. Because that's right, it's potentially a financial investment to have a portal, but once you have it, to refine it is not that costly. So we want to extract as much of the value of it as we can, and of course improve the patient experience. And then the last area, I didn't hear Ed talk about it so much, but I do want to kind of just put in the broader area of patient engagement is the population health management approaches that we're trying to do. And that is also, the extent to which it's technology focused, is about being able to do business intelligence types activities and risk stratification and analysis of the patient base in order to figure out who is it that might be the most needful of an intervention or some contact, so higher level, to prevent future problems down the road. So we're doing a lot in that area in order to bring tools to bear that can take in our EMR data, take in our claims data, taking even some socioeconomic data that we've discovered can be additionally helpful in refining those patients at highest risk. And then we are able to prioritize our contacts from our care coordinators or nurse navigators to the patients for which the value is the highest. And so, that's just another area where on the IT side we can help contribute to operations ability to do the best job possible for the patients.
Yeah, hey, Anthony, can I
go ahead, Ed, please?
Jeff brought up a couple of good points, and I wanted to elaborate on those. When Jeff's talked about the great experience they've had, just like on prescription refills, and for us, one of the side benefits that actually turned out to be the greatest benefit for us is the reduction of volume in our EDs. So here in New York City, our EDs get quite full all the time, and it turns out that we were able to reduce by 80% our volumes, and it was mostly people coming in, and that's how they get their prescriptions refilled. And that was just, maybe that was a cultural thing for 20, 30, 40 years. And by providing this online tool, pretty simple, we've reduced the volume tremendously. So now we can, utilize our ED to actually see injured or sick patients. So that's a great benefit. And when Jeff was talking about population health, it reminded me that one of our strategies had been to, basically in some cases we would try to disintermediate payers by offering our own plan. And in those bids that we did, and we did win some of them, was a whole section on patient engagement. And we use I believe we used a different term than patient engagement, but that's precisely what it was, saying we would have, for patient convenience, for their employee convenience, we would have all these online tools. And so it became sort of a competitive differentiator, if you will. So we might be competing against Aetna or something to get a particular city's employees and in like a accountable care organization. And we were relying on, or part of the sell, if you will, would be these sort of tools that we're talking about. So that's like a whole nother reason to make this investment, not just the clinical outcomes that Jeff and I are pretty passionate about, but also all the financial benefit or strategic benefit from a business perspective.
Ed, when you were rolling out the online prescription renewals and you had the issue with the ED, were you able to push that education to the folks in the ED, the administrative folks, so that they could communicate to those patients, hey, there's another way to do this other than coming in the ED and waiting God knows how long to get your prescription refilled?
Yeah, it was definitely a joint effort, but we didn't really realize that this would happen. So we started, the ED were letting us know, wow, we've seen a reduction and through the administration, and we realized, oh, it's because, we look at our numbers as well. Oh, there's a definite correlation between our rollout and going live with this particular functionality and the reduction in the EDs. And so now the EDs taking that information and capitalized on it, and yes, they do provide that education now for anyone who's still coming in. We still do have people, sometimes it's a social thing, right? I'm going to spend the morning, I want to go, you know, it's a cultural, social phenomena, right? I'm going to go, this morning I'm going to go spend the, you know, the morning, go to the hospital and get my prescription refilled or another prescription. And so there's still some of that going on, of course, but yeah, they're taking every opportunity now to educate the patients because it obviously clears up the ED for them and allows them to get better care, better and faster.
Very good. All right. Well, I think we touched on some of this. Most difficult part of patient engagement is probably getting the patients to care. But Jeff, you want to start off there?
Yeah, I already talked, of course, about the you know, challenges we have with just knowing people's adherence to medications, and that is, I think, a lever that can make a big difference for certain patients, especially those often who have just been discharged and are potentially facing a readmission if they don't keep certain aspects of their condition under control. You know, the other thing we face is, you know, we talk about these technologies as if everybody's savvy with them, and they're not. I mean, we all know that they're not. They're all at different levels. So a great deal of variation in their technical savvy. You know, we do get a fair amount of phone calls from patients wanting help with this, and we actually have that through an outsourced agency to take those phone calls because they're often nights and weekends, and it just made more sense from a staffing area to do that with an agency. But we're a little concerned about what that means as we branch off in the future towards video visits and what it might look like with those patients who struggle just to do basic things on their computer to try and figure out how to make their, make a camera work or a microphone work and that kind of thing. So that's something we have to make sure is part of our plan for support of that kind of thing. And then, there's a lot of opportunity going along with spotting those patients that are deteriorating in some way to knowing that through the availability of interfacing home monitoring devices back to our providers through the portal. We're not doing a lot of that. Our portal does have those capabilities for some brands of monitors, and we just haven't made a big push to encourage patients, certainly those with conditions that would be most beneficial to monitor. But we do have that on our radar, something we really want to leverage.
And Ed, that seems to me that's the point where this gets more complicated from an IT point of view, is when patient engagement moves towards telehealth. And then you've got, as Jeff was mentioning, those other complexities around technologies, cameras, connectivity, all these kind of things. But touch on that, or just the general question of the most difficult part of patient engagement.
Yeah, I'll give you something. So Jeff's right on, and I'll give you something else that I'm sure we all deal with that people can relate to, and it'll be a little bit somewhat controversial. So I'm not speaking about any of the organizations necessarily that I'm affiliated with, but I think perhaps another major difficulty in patient engagement is our own executives. So Jeff and I, Anthony, people on the phone probably get it because we understand the technology, but you have to understand that a lot, I'm not saying everyone, but a lot of executives today, and I don't do age discrimination, but I would say that most of them are probably in the baby boom generation, they still use paper boarding passes, right, at the airport.
Right.
So they're probably not real savvy, and it's not a bad thing. So it's not I'm not making a judgment. I'm just saying on average, that's what I've seen. Probably not super savvy on using some of the technology as people perhaps in generation X or Y. But they're the decision makers oftentimes in our organizations, and they hold the purse strings and make decisions on strategies and stuff. So we can all agree that all these different things we're talking about could transform healthcare, could lower costs, could increase quality. But if at the end of the day, the people in your own organization don't get it, that could be a major impediment. So a lot of times you have to take a step back and educate them,
right,
and
right.
do what you can to educate them and get them further along to understand what the value is. You know, we were very fortunate. We're a long time ago, we realized that we had a problem with readmissions for CHF, and so we came up with a solution where we'd send the patients home with Bluetooth kit, and it worked beautifully. We reduced readmissions by over 30%, and it was very simple, a $150 Bluetooth kit. It was monitored by a nurse. A nurse would look every day, look for variation. If there was a problem, he or she would call the patient, and we did interventions, and, you know, we saved a lot of money, right, because you wouldn't get reimbursed for a 30-day readmit. So the ROI was very, very clear. So when it came time to adding perhaps a second nurse to observe more patients so we could get more patients as protocol when we identified them in our system as high risk for readmissions, that was very hard to get, even though you're talking about, what, $100,000 all in, and the ROI would be in the millions. But not everyone gets it. So that's something that we have to think about is, while we may be really savvy with all the apps and different ways of patient engagement, and we come from it from a technology point of view, not every one of your peers, or my peers, are going to see it the same way. So we have to really double down and educate our peers at the same time that we're educating our patients.
That's an excellent point, and I just wrote down that just because not everyone will engage in high-tech engagements or encounters doesn't mean that no one will. And sometimes you get folks in positions of leadership who just like to shut things down if they don't sort of identify with it or get it. So I think you make a great point about the education, and maybe all this will just come with time as those folks, some of those folks that are not open to these things wind up retiring. Jeff, go ahead, Jeff.
Yeah, if I can add a couple things. First of all, this is a little detour because, I mean, the point about the age of the executives and so forth, I think is worth keeping in mind. But I do have some of our statistics on our adoption of our portal by age group within our patient base, and it's very, over 25% of our our patients that use our portal are between 60 and 80 years old. 33% are over 60, so that, when you add in the people over 80. So it's not something that they're not capable or interested in using. Of course, they're some of our biggest healthcare utilizers, and so they have an incentive to be on the system. But we certainly are not seeing what some people feared, I guess, which was that only the young people would use that portal technology. But I just wanted that aside. I wanted to touch about the other population of people that are potentially doubters that you have to convert to really make this successful and work for the patients, and that's the physicians. We are blessed with strong physician leadership through our multi-specialty clinic model in our large group, which has helped a lot in this regard. But there are definitely folks for whom that was seen as just one more thing that I need to do. I need to look in my in-basket and look for those patient requests, and oh boy, they're going to engage me in this long, convoluted request that's going to take me longer, and I'm not going to get reimbursed for it, and so forth. And so, but if they don't reply to those requests, the patients get turned off really quick, and that can be a real dissatisfier. And so, although many of the questions can be answered by the nurses in the nurse pool, and we always seek to do that where we can, you really also need to make sure the physicians are on board when it does take their responsibility. And through education and through monitoring, through our physician leadership, we've been able to kind of turn the corner on those folks that did that. And of course, big thing you have to convince them is every one of those requests that you get in that form would have been a phone call for which you would have been pulled out of a patient's room or interrupted by the nurse to call that patient back. And so if you can make them think about what that's replacing, I think that goes a long way to helping them feel comfortable in adopting this new way of engaging with their patients.
All right, very good. We're going to do a quick audience poll, see how everyone out there is doing with their patient engagement efforts. I'm going to open the poll now. The question is, how would you describe the results of your patient engagement efforts, or ones that you're knowledgeable of or affiliated with, projects you've worked on if you're on the vendor or consultant side? How do you think people are doing out there? Very well, beating expectations, modest, in line with expectations, or poor? Obviously not super scientific, but we're just trying to get a vibe on how some of the efforts out there are going. So we go ahead and answer that question, and we will move on as you answer it, and then we'll go back and look at the results. This is an interesting question. Do you need, Ed, let's start with you on this. Do you need different strategies? I would imagine you do, for dealing with the well, those who are just in there for something that needs to be fixed, and then they're not going to be in there very often, versus the sick patients, those with chronic conditions that are really need a serious relationship with the hospital?
I think the strategy might be similar, but the tactics different. You know, again, I go back to let's engage patients before they are ever a patient. So while they're just consumers out there, you know, like healthy people tend not to utilize hospitals very much. They might have their annual well exam at a physician office, but they don't necessarily have a relationship with the hospital. And so I think in patient engagement, you know, it starts there, and then through their life cycle, right? There'll be times when they become more, they need your facilities more and more, but you already have this relationship, and hopefully because of your patient engagement strategies, they haven't had to use a lot. But we all know people get sick despite, you know, best efforts, and there's a time for all of us where our lives end. So at some point, definitely there'll be this interaction. So I think the tactics are different as you go along. So, you know, your tactics early on, you may not even have a portal unless, well, through your, hopefully the physician office you do, but they may not obviously have any inpatient episodes in that portal. So it's more about wellness. Have you had your annual PSA screening? Have you had your, you know, your mammogram and those sorts of things? And so it's pretty light touch. There might be some games and just some fun things. And then as someone gets sicker and they have to get engaged more acutely with you, I think the tactics change. And so, yeah, I think for me, maybe it's just a nuance of words, Anthony. I think the strategy is the same, you know, about patient engagement and reaching out from cradle to grave, but the tactics within that time frame have to adjust according to where the patient is.
Very good. Jeff, your thoughts around that, and do you see other segments that you need to separate patients into when you're approaching this?
Well, just on the first one, just if I can cast it in a slightly different dichotomy, I kind of think of it in terms of acutely ill, and not hospital acute, but like I've got something right now that I need to get dealt with, and then there's the more chronic conditions for which we, you know, are going to have an ongoing relationship, like I said.
Right.
We also just touch on what Ed said before about the competitive advantage of coming up with good alternatives for patients to seek help and seek health is the challenge that we face, and I think a lot of other folks across the country face, around these teledoc services that are starting to, you know, be offered, where you can reach somebody 24/7, 365. So if you are somebody who has that acute thing, wake up in the middle of the night with a respiratory issue or a urinary tract infection or something that you want to not quite at the level of requiring 911 or an ED visit, but want some relief, there are services out there where you can reach. And if we are not trying to at least offer much more convenient options than we do today, we're going to lose some of those patients to those options real quick. The good news, I guess, is that on the more chronic conditions, they typically need a range of services and a more specialized levels of care or specialist activities for which we have a broad portfolio. So I think we are able to be appealing to that group population and treat them in a very comprehensive way. And so the strategies might be a little different as far as capturing and building that long-term relationship and level of care for them. But you can't forget about the episodic, folks that have something acute that comes on and they're looking for help immediately, or as immediately as they can get it.
Very good. All right, we're going to take a quick look at the results. 8% have said they're doing very well and beating expectations. 85% are doing modestly well and in line with expectations, and 8% did not achieve their goals. So a huge majority, vast majority in the middle. Ed, any thoughts on that result?
I'm not surprised. That's been my experience as well. Not as well, because to Jeff's point early in the conversation, there's other industries that are so much further advanced. Living in New York City has opened up a whole new world to me in terms of all the ways that I'm engaged now as a consumer, because just of the dynamics of living in a major city like New York City. From anything from personal shopping to your groceries to how you get anything, everything's online. And
right.
So I think about that, and other people are having the same experience, and then trying to find healthcare, there's a big gap. And so I think we all have, probably the type of people that are drawn to this conversation, we all have big vision and understand what's capable, but yet in our own organizations, we're not quite there yet, because healthcare, I think, tends to be a little bit of a laggard. So I could see why most of us would kind of be in that modest area, and I'm just hoping that we keep applying these strategies, we keep looking for the results and execute well, and I think over time it will hopefully change to be very well and beating expectations.
Jeff, we don't know where people are setting the bar, right? So it's tough to interpret a question like this and the results. But to me, it's a great sign that only 8% feel they're doing poorly, because I had thought it maybe a year ago that people were really frustrated trying to meet the government requirement of getting people to log into the portal and these type of things. So maybe only 8% feel doing poorly is pretty good. What do you think?
Yeah, no, I don't know the stats from last time, but this one I think is good. It shows that people are setting, to the extent to which they're setting a goal of what they want to achieve, they're meeting it, and I think that's really important. But I'm not sure 100% that this is stated or interpreted in terms of their own attendees' own expectations, or whether it's the patient's expectations, which I would worry that I wouldn't be able to rate ourselves very highly. When it truly came to where our patients' expectations are going, which I think Ed talked about very well.
Right. The patient's expectations is could be different from the organization's expectations. And then we talked about the segmentation of the patients, and those that Ed mentioned that are ordering groceries online and getting Ubers and all these kind of things have different expectations than my father, who still has an old phone. He doesn't have a smartphone, and it's got some Scotch tape on it. So, that's a bit of an issue. We'll work around that. All right, let's go to our next question. I want to remind everyone to go ahead and send in any questions that you've got for our panelists. Otherwise, we'll just keep going for about another 5 or so minutes. Ed, you want to touch on this one? What role does age, and you mentioned you're not an age discriminator, but there are differences. What role does age or any other socioeconomic criteria play in developing patient engagement strategies? For example, those in rural areas might have connectivity. Those in urban areas may have people that don't have devices or things like this.
Yeah, I think to Jeff's point earlier, it is shifting even for our older generation. My dad's 83, and we got him an iPhone for Christmas, and he was already on Match.com and found his future bride. So,
congratulations!
Yeah, so to think that we would get him on a portal is not that big of a stretch anymore, as it would have been perhaps 5 years ago. And so, I think we are seeing people changing and more open to it. And I don't know the statistics off the top of my head, but I've seen some, but Jeff had some good ones about their own experiences, specifically Trinity and Mother Francis, and it's right. I think it's very reflective of the trends that even the baby boomers, even they are adopting the technology, getting more and more savvy. So I think that's changing. My point was really about our own executives, and just travel with them and see if they use paper boarding passes. That'll tell you everything you need to know in terms of how much work you have left in front of you. So I think the strategies do differ, and from rural, in New York City, so even in a big city, it may not have to do so much with the type of demographics we're thinking about, rural versus city, but within a city, undocumented individuals versus documented individuals, and just their own cultures that they have, and sort of hidden, but they're not hidden when they need health care. And so it adds another layer of challenges. So I think it's harder probably for rural, although I don't have a lot of experience there. Jeff might because of the location of Tyler, Texas. But I think even within a city, you're going to have different challenges depending on the demographics of the city.
All right. Jeff, do you want to touch on that one?
Well, yeah, we certainly have a great deal of our population are in rural areas, and internet connectivity is a real problem in some of those areas. But cellular penetration is greatly improved too. So I think there is a little bit of leapfrogging to folks that either whether they can't afford a computer or just never had an interest or never had one, do have smartphones, and so I think there's a real opportunity to kind of convert them to using the apps like our portal and other things. It'd be interesting to see if there's a shift. I'm just speculating here, but I mean, I know the power, and we've all seen this in the last few weeks with Pokemon Go, the power of gamification, right? I mean, I think, as it relates to getting patients engaged in the care, to the extent to which you can make it something to which there's a score and the goals are measurable and meaningful and achievable, in the eyes of the patient, and you give them a tool to help track that along that, and make it seem like a game, earning points, things like that. These aren't strategies that I'm saying we're actively pursuing, but I think it's becoming a trend out there. So a lot of people who have those smartphones, their primary reason is to play Candy Crush or something like that. So if we can make this kind of stuff be anywhere near on the par with giving them some sense of reward from making that product meet their needs, I think it would be interesting to see how that shifts people's behaviors.
All right, Jeff, let's stick with you. We've got an audience question in. For less mature organizations with limited resources, what patient engagement tools, and we're not looking for specific vendors here, just types of tools, would you recommend that offer the most bang for the investment?
I'm not sure. I have a good answer for that one, Anthony.
We can kick it to Ed while you think about it.
Yeah. Why don't
All right, let's turf it over to Ed.
Well, I think Jeff and I actually touched on it a little bit early in the conversation. But I mean, a simple one is just an online presence that could have, like, part of your website for your organization. Everyone has that by now. You could have, what is my heart age? Or you can identify, let's just say diabetes is the biggest issue in your community. You could have something related to diabetes, and people could do a little survey. People love taking short surveys, and you can incentivize those surveys, and you find something out, but you're getting that engagement. And sometimes when people do these sort of things, healthcare organizations, you get the name and email of the particular person doing this, and you can follow up with them. And that's really an easy first step in this process. And I think for less mature organizations, and I'm part of one now, is you take these little baby steps and you build on the success of these, and then you start seeing greater reward. But you have to do the things that we talked about as well. So try something really easy. It's very inexpensive. At the same time, start educating to Jeff's point earlier, start educating your medical staff, start educating your fellow peer executives. Get them engaged, and then try to lead by example. That's what I always stress too. You got to be out there and showing people, even if your own organization doesn't do anything, maybe you're doing Pokemon Go or some other application. There's so many apps in healthcare, as we know, that are independent organizations, but just show them how you're using one, or you use iPhone, you already have one built in. And whether it's steps or things like that, those are ways of engaging. And I think you'll find an ally with HR, because they understand sort of the getting a healthy workforce. And so you can start in these different areas and just build momentum. And you'll never be successful if it's just you. So that's why I'm saying, go to HR, you might find some good allies there. And maybe there's another executive, one of your peers, that's really into health or fitness, and start building a coalition, because that's what it's eventually going to take in order for you to get the funding you need to prove these things out.
And Ed, you've been talking about this for years. You've been writing about it and talking about it. The fact that essentially, as a CIO, you have two jobs. One is the CIO role, but the other job is to get buy-in on your agenda by building relationships with the board, with the rest of the C-suite and key medical staff. Otherwise, you're not going to move your agenda forward. Is that correct?
Right. You're going to, you're going to be frustrated because it's never about one person. And so no matter how great of an idea you have or how great of an IT person you are or how great of an executive you are, if you're not building a broader coalition and getting other people involved and in many cases letting them be the person out in front while you're feeding them behind the scenes, you're not going to be very effective. So I think the key to everything is just be humble and build these relationships, take a secondary role if that's what's needed. Sometimes you have to be up front, sometimes behind, and move that agenda forward. And get people like, we're getting ready now to send a bunch of people to a particular user group for our particular vendor. And I'm like, well, how many of the executives have gone in the past and how many have been invited? And it turns out none. And I'm like, no, it's crazy, it's crazy. As much as I want to send my staff, we also want to send a bunch of other executives because we want them to learn and meet their peers across the country and how they're using the system. So there's all sorts of ways of doing that, but it is really, really critical that you make it less about yourself and more about the organization and getting others involved.
Yeah, and if I can build on that, I mean, we first of all, your point about HR I think is huge because that serves as a jumping off point for our organization as far as driving for our own self-insured population to become more healthy and cut down our Medicare costs, medical costs, and we but in encouraging that of our patients, our own employees, they became better spokespeople for those kinds of things to the patients that they're treating in their day-to-day work. So I think that has a great aligned ripple effect benefit because there's the financial benefit of you doing better on your own self-insured plan, but also building a kind of a set of advocates out there in your population. But then the other point about your executives and their participation and abilities to understand the capabilities of the technology, it makes such a difference when you have folks wanting to pull from IT instead of you having to push IT. And,
great point.
We see that with reports that somebody says, well, we just found enough data in this organization, but if they're not willing to work and explain what it is that they want to take and how they intend to use it, then we have a really hard time just coming up with that unilaterally. And then this whole MyChart initiative, a lot of that has been driven by our executive over our primary care institute who has been here about 18 months, and this is just a huge difference from the amount of executive level push I was getting for some of these patient engagement strategies. We're over here saying, hey, there's these great tools. There's the population health products and the portal products, and we're doing our best to build them, but but we're having trouble getting physicians to engage or to engage the patients on it. Once he came on board, it really, lit a fire because he saw all the clinical benefits and was pulling it out of us and challenging us to do more and more in a way that was going to not be speculative about what the business needed, but was actually driving to stated objectives. That really helped us a lot.
Excellent. Well, that's where we're going to wrap it for today. That was a tremendous conversation. I want to thank our panel very much, Ed Marks and Jeff Pearson, for joining us. When you close out your WebEx window, you're going to get a quick survey pop up. Please it'll take you less than a minute to answer it, so we'd appreciate it if you would do that. You'll get an email when this archive has been posted to our YouTube channel. For those of you who have the CHIME CHCIO certification, let CHIME know you were here. You get 1 CEU. If you've asked us to let CHIME know, we will. Sponsorship opportunities, you can contact Nancy Wilcox, and if you need a certificate of attendance for another CEU program, you can use the final slide. And you can go to our website to see our upcoming schedule. So once again, I want to thank Ed, Jeff, our audience. Everybody have a wonderful day. Thank you.
Thank you.